You can see number of participants also. Okay.
Okay, so a very, very good morning, ladies and gentlemen, doctors, colleagues. Thank you very much for coming on this morning for this latest installment. I would probably call it the final installment of 2020. And with the exception of the wonderful series that this has been, we all hope to bid goodbye to 2020 and hopefully get a good year next year. It's been a horrid, horrid year. Hopefully it's a bright year. But what's good that's come out of it, I suppose one of those little things is things like these sessions, which now has been a way for us to get together across so much of distances. Today's the penultimate kind of session for this year for the SK Dharmalingam lecture series. So as you know, it's a series on experts speaking to all of us in primary care, in general medicine, about how to kind of pick up cancer early, kind of speak to us about advances in cancer, and all these various types of cancers. And over the months, we've been very fortunate. We've been very lucky and blessed to have with us an exceedingly esteemed faculty of lecturers, speakers, senior physicians, and today is no exception. So today, please allow me to first introduce our speaker for today's session, Dr. Murali Sundaram. I am very especially excited. So it's the first time it's Murali and Murali. Dr. Mr. Murali Sundaram is, I think, needs no introduction, but I will introduce him anyway. I have the great privilege of doing that today. Dr. Murali is a very senior urologist, and for many years, he helmed a lot of the services of urology under the Ministry of Health, Malaysia. A lot of the things that we do today as current practice was developed by Mr. Murali and his team over the years, countless numbers of people that they have trained who are now working in many hospitals, both here and abroad. So we're very, very fortunate and blessed, like I was saying, ladies and gentlemen, to be able to get his insights today on us. And interestingly, he's going to speak to us from a very cutting edge perspective. On the idea of robotic surgery and prostate cancer. And what's very interesting is perhaps 10 years ago, we were watching Star Wars movies or Star Trek movies, and we were speaking about, wow, will there ever be a time when we'll see robots operating on humans? And really one of the big innovations has been the use of robotics. And one of the leaders in that area has been urology. And today, I think robotics is an integral part of management of prostate cancer. And we're very excited to get one of the pioneers who started perhaps this entire kind of advance within this entire region. And he's here today to share with us a little bit of insights pertaining to this. So without further ado, please let me turn this over to Dr. Murali. Thank you, Doctor, and always a pleasure once again to have you with us.
So I will share my screen now. Screen sharing. Hi, Murali. Can you see my screen?
Yes, I can, Doctor.
Okay, fine. Okay, I'd like to thank my namesake for that very gracious introduction. And good morning, everyone. So I thought maybe today, instead of always talking about diseases and treatment, maybe we'll just shift directions and talk a little bit about medical technology. Okay, so my lecture will be in two parts. The first part is just a story, the story of robotic surgery. And the second part, I will talk a bit more, prostate cancer and PSA. So these are the topics that I'll be covering for the first part of my lecture: the history of robotic surgery, what are the pros and cons of this new technology, how has the development of robotic surgery been in Asia, and what is the future of robotic surgery? Like as Dr. Murali said, Star Wars, this is R2-D2, the cute little robot in Star Wars. And we never thought that, in our lifetime, we would see robots actually in the operating room. So when I started my career in surgery about 30 years ago, it was the era of open surgery. And my teachers used to teach me, big surgeons make big incisions. Don't make a small incision and struggle. Exposure is everything to success in surgery. So that was a dictum that I was trained with. Now, all this changed somewhere in the 1990s with the advent of laparoscopic surgery. Laparoscopic surgery is a form of MIS. MIS means minimally invasive surgery. So what it means is the incisions that we use to get into the abdomen are now very, very small, minimal. The job that we do inside is the same, is as big as if you had open surgery. Okay? So the famous and the first laparoscopic surgery that was invented was for gallbladder. Now, when I was training, all the gallbladders that we did was by open cystectomy, where we made a cut somewhat like this and took the gallbladder out. But in the 1990s, with laparoscopic surgery, instead of making a cut like this, they would put these small little ports into the abdomen, and through one of the ports, they would instill carbon dioxide. So the carbon dioxide will fill up the abdomen and give you a pneumoperitoneum. That means there'll be a lot of gas in the stomach, in the abdomen, and that provides a space for which you can do your work. And so laparoscopic cystectomy was the first form of minimally invasive surgery. I remember when it first came about, there were a lot of protests from open surgeons who had built their name, doing open surgery. There was a lot of resistance. They said this form of surgery is unethical, it's very dangerous, you can't see what you're doing, you're bound to run into a lot of problems and complications. And so there was this debate early on in the field during laparoscopic surgery. But of course now, laparoscopic surgery, or also known as keyhole surgery, because it's only very small holes made in your abdomen. Laparoscopic surgery nowadays is the current standard of care. Most patients who want to have surgery always ask, can we have the surgery where you make the small holes? And of course, the reasons why laparoscopic surgery has become mainstream is because of its obvious advantages. Okay? And these advantages include smaller incisions, better cosmetic scar, less blood loss during the surgery, less use of analgesics after the surgery, faster convalescence and recovery of the patient, and a shorter hospital stay. So the benefits of laparoscopic surgery are obvious. However, it soon became apparent to us that there were limitations of laparoscopic surgery. The laparoscopic surgeon had very poor ergonomics when he performed the operation. You can see the surgeon here and the picture below. The surgeon's hands are in very, very awkward positions. Okay, his head is in an awkward position. So this form of surgery has got poor ergonomics. Okay, and the movements of these long instruments, they are counterintuitive. Counterintuitive meaning, if you want to move to the right, you have to move the instrument to the left in the opposite direction. There was also a lack of depth perception, because you're basically looking at a TV monitor, which is only 2-dimension. So you lack the depth perception. And because of all these limitations in laparoscopic surgery, there was a steep learning curve for complex procedures. Simple procedures like, taking out an appendix or taking out a gallbladder or taking out a uterus was pretty straightforward. But when you had to perform reconstructive surgery, then it became a bit more complex, and it took a long time to learn these procedures. During that time, in the 1990s, NASA was experimenting with Tele-Robotics programs. And here they were experimenting with sending robots, into terrains that were dangerous terrains. For example, outer space, deep sea explorations. They didn't want to send a human being into all these kind of dangerous environments. So they thought about this idea about sending a robot which could be controlled by a man. Okay, so this is called the master-slave concept. This is the slave and this is the master. And they were thinking of using robots in these kind of very unfavorable conditions. NASA even thought whether it was possible to operate on astronauts in space using a robot which was controlled by somebody on Earth. So this was all the ideas that they were coming up in those days. Other agencies, US institutions like the US Defense Agency or DARPA, they, in collaboration with Stanford Research Institute, were looking at other ways in which robotics could be used. And they were thinking more of in the line of battlefield robots. Because the defense agency, during these times, the US was involved in multiple warfare overseas in several countries. And when the soldiers got injured in battle, they had to send in the medical doctors to go and operate with the surgeons. And this puts the medical team at risk of getting killed. So they were thinking, why not we send a robot into the battlefield, and the surgeon can then operate the robot safely far away from the front lines. So this was the idea behind Tele-Robotics for surgical battlefield robots. So during during the late 80s and the early 90s, there was a lot of research going on in the US regarding robots for medical purposes. And actually, you'll be surprised that this idea of robots was not new. Leonardo da Vinci, way back in the 13th century, he already kind of thought of, wouldn't it be nice to have a mechanical knight that could do the biddings of a human master? So he actually drew up the plans for a mechanical knight. So Leonardo da Vinci was way ahead of his time. So in 1995, all this research in robotics in the US culminated in this US company known as the US Intuitive Company. They came up with the first commercial robotic system in 1995, based on the years of research in robotics done in the US. And they named it after Da Vinci, because this guy was ahead of his time. They named it after Da Vinci, and they called it the Da Vinci surgical system. Now, this surgical system, which came out in 1995, consisted on 3 components: the surgeon's console, and this is where the surgeon sits. So he's got all these controls on his hands and his feet. And from this console, the surgeon will operate the robot. And the robot here is called the surgical cart. Okay. The third component contains all the hardware that is required for this computer interface. It's got the TV, it's got all the computer systems, it's got the light source, the laser equipment, and everything else you can imagine. So in the operating field, in the OT, in the OR, this is what it looks like. The patient will be lying on this bed here, And the robot will be putting its arms into the patient's abdomen and performing the surgery. But in actual fact, this robot is being controlled by the surgeon who sits at the console. So it's the master-slave kind of concept. The master sits here and he controls the robot. So if you look at the robot, the Da Vinci robot has got 4 arms and it's named number 1, number 2, number 3, and number 4. One arm, the center bit here, holds a very special kind of camera. This camera, if you look at the end of it, it's got 2 optical images. So the computer system is able to marry the right eye and left eye into a single image, and this gives the surgeon a 3-dimensional view of the entire operative field. Unlike the laparoscopic surgeon who only gets a 2-dimensional view. So in addition to the camera arm, which gives the surgeon the 3D vision of what's going inside your tummy, you have another 3 arms which can hold a variety of instruments. And these are some of the instruments that we use in robotic surgery. They are scissors, they are needle holders, laser pointers, and all kinds of instruments. And these instruments are very, very small. You can see here, this is an American penny. And the instruments here are smaller. The head of the instrument, which actually does the job, is smaller than the size of an American penny. So it gives you the size, it gives you an idea of how small and delicate these instruments are. And this is the master control. This is where the surgeon sits, where he operates the robot. So you can see ergonomically, the surgeon is very, very comfortable. He gets to sit down. His arms are in a very ergonomical position, as is his neck and head. Because he's far away from the operative field, he does not have to be sterile, meaning to say he does not have to wear a gown or a mask or any of that stuff. He doesn't have to wash his hands or anything like that. And from this console, he gets a 3D telescopic view of what is going on inside the abdomen. This system also gives him a 10 times magnification. And the whole view is in high definition. So in reality, he gets an enhanced view. He gets a superhuman view like Superman. He can see, 10 times magnification in high D and in 3D. In addition, this system also allows him to have a digital platform with integrated imaging, meaning to say, while he's operating, he can also view the patient's records, for example, CT scan, MRI, ultrasounds, while he's operating. And this allows him to have a better understanding of where he's operating. Okay. Now, augmented reality, I will talk about it in a little while. Now, the whole heart of this system lies in this special technology, where the movement of the surgeon's arm at the surgeon's control is translated almost seamlessly to the movement of the robotic arm. And this is the magic of the system. Now, this robotic arm, which performs the surgery, has the same 7 degrees of movement as our human hand. The human hand has got 7 degrees of movement. That means to say there's 7 individual movements to our hand. And the robotic arm, the robotic hand, has the same 7 degrees of movements. And this computer interface allows the human movements of the surgeon's hand to be translated almost seamlessly and accurately into the movement of the robotic arm. In laparoscopic surgery, the instruments are very rigid and straight, and they only have 4 degrees of movements. So they don't have the same degree of movements as the human hand. And also built into the machine itself is this tremor filter. Now, all of us have a little bit of a physiological tremor. You know, in some people it's more pronounced, in some people less. And this robotic system has a filter so that your hands don't kind of tremor when you're doing the surgery. So this is a video on how the robot actually operates. Down here, the surgeon is performing the operation in virtual space. And up here in the patient himself, the robot is just imitating the surgeon's movements. But he's imitating the surgeon's movements so precisely, you know. This suture that the robot is using is a 6-0 suture. 6-0 suture is about the size of a strand of hair. So it's a very, very delicate suture, and the robot is able to perform the operation almost precisely following its human master. So if you were to look at the pros and cons of laparoscopic versus robotic surgery, the laparoscopic surgery, the instruments are rigid and only have 4 degrees of movement, whereas in robotic surgery, the robotic instruments have 7 degrees of movement and they move intuitively. Laparoscopic surgery requires counterintuitive movements, meaning if you want to move right, you actually have to move the instrument to the left. Whereas in robotic surgery, the movements are intuitive. Intuitive means the instruments and your hand move in the same direction. It's like when you drive a car. When you're driving a car, you don't really think of what you're doing. The movements are intuitive. If you want the car to move to the right, you just turn the steering wheel to the right. If you want the car to move to the left, you turn the steering wheel to the left. You don't really think what you're doing. So the robotic surgery is like that. It's just intuitive. And that's why the robotic company is called intuitive surgical, because the movements are so intuitive and it's easy to learn. And of course, there's improved ergonomics because the surgeon is seated very comfortably, and this leads to less surgeon fatigue. And there is a very short learning curve in robotic surgery as compared to laparoscopic surgery, which has a steep learning curve, especially for complex reconstructive surgery. Now, the disadvantages, of course, is the robot is a big piece of equipment. It's got a huge, as you say, got a huge footprint. You can imagine these 3 components sitting in an operating theater will take a lot of space. Also, there is no haptic feedback. Although the surgeon has superhuman vision, he cannot feel the tissues. He doesn't have a sense of touch, okay? And of course, the biggest disadvantage to robotic surgery is the cost of this equipment, okay? And when the Intuitive company came up in 1995 with this robotic technology, there were problems. There are always challenges when it comes to adoption of accreditation of new medical technology. The same thing happened when laparoscopic surgery was introduced. There was a lot of people who were naysayers and said this technology is dangerous. So whenever new medical technology comes into the forefront, these are some of the challenges. First is ethical and legal considerations. Is this technology safe? You would need special patient consent to tell them, look, this is new technology, we have to try it out. As with any new technology, there is a learning curve. Now, how long is learning curve going to be? Is it 50 cases? Is it going to be 100 cases? Is it going to be 1,000 cases before you learn? And pioneers who start using new technology have to keep a close audit of the outcomes, because all technology must have FDA approval before it can be rolled out to the general public. There's also the question of reproducibility of results. That means to say, if one hospital or one surgeon gets very good results with a certain technology, does not mean that his results can be reproduced by others. For example, in laparoscopic surgery, there are master laparoscopic surgeons who can perform all kinds of procedures laparoscopically, but their results are not reproducible. That means to say other surgeons who are less experienced cannot perform the surgery. So reproducibility of results is very important for any kind of medical technology. Then, of course, as I mentioned, you always get resistance from your peers who are used to the old form of surgery or the old technology. There's also the question of multidisciplinary usage. Like as I mentioned, robotic technology is very expensive. So if this technology can be only used by a small section of surgeons, then it is not cost effective. You have to come up with technology which can be used across the board by many, many surgeons, and this will increase the cost effectiveness of this technology. So when the robot first came about in 1995, it was brand new technology waiting to be used, and no one really knew how to use it. So it was up to this guy, this doctor was named Dr. Mani Menon, and he was a consultant urologist at the Robotic Institute in Detroit Hospital, Chicago. And he has often been referred to as the father of robotic surgery. Now, Dr. Menon was a surgeon who did prostatectomies, radical prostatectomies for prostate cancer, which was done at that time. It was done by open surgery. So he thought to himself, now, maybe I should try laparoscopic surgery for prostate cancer, because with the smaller incisions, less blood loss, my patients were very happy. So he tried to perform laparoscopic surgery, and he found that he was useless at it. It was far more difficult than he anticipated. So when the robot came about in 1995, he thought to himself, now, why don't I use the robot to perform this radical prostatectomy for prostate cancer? It looks much easier. The learning curve is much better. So he was the one who persuaded Vatikuti. Vatikuti was an Indian philanthropist. He persuaded Vatikuti to donate a huge amount of money to Detroit Hospital in order to purchase this new technology. And it was his pioneering work in the field of robotic surgery for prostate cancer that finally led to FDA approval of this machine for prostate cancer in the year 2000. And this is how this is how robotic surgery started in the US. Now, that was way back in 2004. Now, in 2010, I had the opportunity to write this article entitled Asian Robotic Experience, and this came out in Urological Oncologies in 2010. And at that time, there were about 60 of these robotic systems in Asia. You can see down here, Malaysia is down here, Singapore. And so I think we had 2 systems in Malaysia at that time, and Singapore had a couple, and there were some in Thailand, a few in India, a few in China, Taiwan, Hong Kong, and Japan. Now, 10 years later, there has been a 10-fold increase in the number of machines just in Southeast Asia. From 60, the number now is more than 700, I would think. So there has been a rapid expansion of robotic surgery in Southeast Asia, and many health systems across Asia have invested heavily in this new medical technology. This graph looks at the robotic procedures in Southeast Asia over a 5-year period from 2014 to 2018. And you can see there is a constant gradual rise in the number of robotic procedures done in Southeast Asia. Now, the ones in blue, that is urology. So you can see urology is still the #1 user of robotic technology, but there is slowly increasing use of the robotic in other fields, for example, cardiac, thoracic, pediatrics, head and neck, gynecology, and general surgery. And therefore, the robot slowly is becoming a multidisciplinary tool and is being used in various different specialties in surgery. Now, why is urology still a prime user of the robot in Southeast Asia? Because, as I said before, the robot in urology is mainly used for prostate cancer. So, this chart here shows how the incidence of prostate cancer in Asia has been changing. So this graph, or chart rather, looks at the incidence of prostate cancer comparing the 1970s to the 1990s. And it shows what is the percentage change in these two eras. And in some countries like in Singapore and Japan, you can see that the rise in the incidence of prostate cancer is more than 100%. So, and this is mainly due to the fact that there's been increasing use of PSA testing in the more developed countries of Southeast Asia. The other reason for the increased incidence in prostate cancer is, as you all know, prostate cancer occurs in the elderly people. Excuse me. Hello. I'm on a webinar now. Call me later in 2 hours time. Yeah. So as I was mentioning that prostate cancer occurs in the elderly, more than 65 years of age. And you can see from this WHO prediction here, in Southeast Asia where we live, the number of people who are going to be more than 65 years by the time we reach 2050 is going to increase by a staggering amount of 430%. So just think about it. By the year 2050, the number of people more than 65 years old in the Southeast Asian region is going to increase by 400%. And so a lot of these people, especially of course the males that we're talking about, are going to have prostate problems like BPH and prostate cancer. And therefore, there is going to be a lot of work for urologists, in the future in Southeast Asia. And the other thing about prostate cancer in Asian men, all these studies down here have alluded to the fact that Asian men, as compared to the Western population, prostate cancer occurs in a slightly older age, and we tend to have more advanced tumors and more aggressive tumors. So that's just, a snapshot of what we can expect for Southeast Asia as far as prostate cancer goes. So as Mani Menon used to say, the speed of robotic expansion worldwide has rivaled that of the internet, the cell phone, and the personal computer. The way that robotic technology has revolutionized the surgery is really quite fast. So robotic surgery in Malaysia started in 2004. So that's quite surprising really, because, the FDA only gave approval for robotic surgery in 2000. And within 4 years, Malaysia, we managed to get our first robotic system. And at that time, when we got our robotic system, it was brand new technology. There were less than, I think, 10 machines in the whole of Southeast Asia. So it was brand new technology. No one knew how to operate it. There was no one from Southeast Asia whom we could ask for advice. And so we decided that we would get the help of Money Menon and his American robotic team, because at that time they were the best team in the world. They were known as the American Dream Team. They were the guys who had all the experience. So through the Intuitive company and through sponsorship of the company, the robotic company, Money Menon, who's up here, Money Menon and his robotic team came down to Malaysia, and he brought along his own nurses. He brought along his own anesthetists. He brought along his own trainees, consultants, and so they all came to Hospital Kuala Lumpur, and they stayed with us for 2 weeks, and they performed a lot of surgeries with us. And they ran some workshops. These are some of the team from Detroit: Ashok Hemal, James Peabody, Alok Srivastava, Kitan Badani. These were all young pioneers when they first came to KL. Of course, right now, 20 years later, they are all very famous robotic surgeons in the US. But at that time, when they came to KL, they were just early pioneers in robotic surgery. And then a year later, the Money Menon and his team again visited us. And this time he brought along other specialties. For example, Jack Elder was a pediatric robotic surgeon, and Craig Rogers was a specialist in robotic kidney surgery. Over the years, we've had other mentors besides the team from Detroit, And the team from Detroit also brought along with them technology from the US. And they set up this audiovisual room in Hospital Kuala Lumpur, and they gave us a demonstration of how to use 3D technology, so that the audience in the audiovisual room could actually visualize the operation in 3D using these 3D glasses. And here you can see the health minister at that time. Dr. Chua was the health minister at that time, and this was my boss, Dr. Shahabuddin, who was instrumental in bringing robotic technology to Malaysia during those early days. We also had experts coming from other parts of the world to come and help us, David Bala from Duke University, Professor Kunra, this handsome looking guy, Professor Kunrai from Severance Hospital, University of Yonsei, David Willett from the Bristol Urological Institute, Dr. Murphy from Australia, and of course Viv Patel, who's probably the most famous robotic surgeon, who has performed more than 3,000 robotic operations. All these people took time out from their busy schedule to come and help us in those early days when we were just struggling how to use the robot. Of course, 20 years later, we don't have to ask all these famous guys from Europe and America to come, because there are many well-established Asian robotic training centers now. And one of such center is the Yonsei University in Seoul, South Korea, with their motto, Yonsei, the first and the best. And in Korea, robotic surgery is so popular that it's even advertised in the tube stations and the malls, and all the Koreans know about robotic surgery. Bill Gates, who had a vision in 1975 that there should be a computer in every home, the University of Yonsei is that there should be a robot in every OT. I also had the opportunity to visit People's Liberation Army Hospital 301 in Beijing, where Prof. Zhang Zhu has a very established robotic unit there, and they perform many different types of operations, and they have published their works in the leading robotic journals. So we have our own Asian robotic training centers where we can visit. Now, I was going to talk to you about tele-mentoring, and this is what I mean. You may have read about this patient. He he had a tumor in his stomach, in his tummy, and he wanted to go over to the US to have it operated by a famous robotic surgeon in Seattle. However, this occurred right in the middle of the COVID period. So he couldn't fly to the US. He was a UK citizen and he was in London. So what he did was he went over to his local robotic surgeon in London who did the operation. But with the use of augmented reality technology, the surgeon from the US was able to monitor, was able to guide the surgeon in the UK to perform the operation by the use of telemetry. And here you can see the surgeon's hand from the US pointing out to the surgeon in UK, you know, where the tumor is, where the margins of the tumor, how to cut, you know. So this kind of telementoring is possible with augmented reality technology. It also increases the learning opportunities in robotic surgery, in the sense that the guy who's going to teach you robotic surgery doesn't really have to be in your theater. He doesn't have to fly in from the US. He can do it from the comfort of his own home using this kind of technology. So my last few slides will be on the future of robotic surgery. So the Da Vinci system, as I told you, has four arms. And that means to say you got to have 4 little holes in your tummy. But now the Da Vinci system has come up with a single port. A single port means there'll only be 1 hole in your tummy, and through that single port, all the other arms will come out like an octopus, and they'll be able to perform the surgery, but you only have a single hole in your tummy. So that's single port surgery. And of course, the Da Vinci company will also experiment using other forms of energy devices in order to do the operations more effectively. And recently, the Da Vinci company has also come up with this concept of having a dual console. That means instead of having 1 surgical console, there are 2 consoles here. The surgeon sits on 1 console, and the trainee, the guy who's learning how to operate, sits on the other. And both of them can control the operation. So initially, the trainee will be allowed to start the operation and perform the simple steps. And when it comes to a difficult step, the master, the mentor, can take over the controls, perform that part of the operation, and then hand the controls back to the trainee. So in this way, the learning curve of the surgeon is greatly enhanced with robotic technology. There was this study done, published in the British Journal of Urology, which looked at the learning curves for urological procedures. And they reported that if you were doing the operation in an open fashion, your learning curve, you would need to do something somewhere between 250 and 1,000 cases before you're proficient. If you were doing it laparoscopically, you would require maybe somewhere between 200 to 750 cases to be proficient. But the learning curve with the robot is greatly reduced to 50 cases. So what this means is the operation for prostate cancer can be done in an open fashion. It can be done laparoscopically. It can be done robotically. As long as a surgeon is very experienced in the procedure, it doesn't really matter which technique you use. But for the surgeon to get experience in open or laparoscopic, he has to take a long time he has to do a lot of cases before he's proficient, as compared to the robotic surgeon who can do it a lot faster. And that's the beauty of robotic surgery. Robotic surgery has also been used in cardiac surgery. Now, in cardiac surgery, classically, you have to do a median stenotomy. That means you have to split the chest right in the center to be able to get in and do your operations in the heart. But for the robot's hands can go in between the rib cage and perform surgery, and therefore valve surgery, bypass surgery is possible to do it robotically. As I mentioned, the University of Yonsei is one of the main training centers, and in Korea, a lot of the Korean women, for some reason, get papillary cancer of the thyroid. And Korean women are very cosmetically, conscious. They don't like this. They don't like a incision in the neck. So the Korean surgeons came up with this idea of performing thyroid surgery using the robot, but going through the axilla. They make a cut in the axilla, and then the robot goes through the axilla under the skin to remove the thyroid gland without having a scar in the neck. And this operation, robotic thyroidectomy, was actually devised by the people in Yonsei in Seoul. The robot has also been used for transoral robotic surgery, where the robot can go through the mouth to perform complex surgery on the oropharynx, and this is ENT. It's known as transoral robotic surgery, or TORS. Robotic surgery has also been used in the field of kidney transplantations, although it is still experimental at this stage. The robot has also, now we've been talking about the Da Vinci robotic system, but it must remember that robotic surgery, there are many other types of robotic surgery besides the Da Vinci machine. And for example, in knee replacement, robotics has been used to ensure that when you replace joints, the joint axis must be very, very accurate in order for your joint to work successfully. And therefore, robotics has also been used in orthopedics, being increasingly used in orthopedics, has been increasingly used in orthopedics to perform surgery, accurate surgery. And what about eye? Eye surgery is one of the surgeries which require, precise, a lot of precision. And this system, which is known as PRECISE, has been used by the vitreoretinal surgeons to improve their accuracy in performing this type of surgery by a factor of 20. You can see here the gross movements of the surgeon's hands are translated by this robotic system to very fine movements inside the eyeball. In the field of cardiac stenting, as you know nowadays, a lot of people don't go for bypass surgery, they go for cardiac stenting. And tele-stenting has been performed in China and in India, where the person who does the stenting actually is sitting in an urban hospital and he's performing surgery on the patient in a rural setting. And this is known as tele-stenting. And this has been performed successfully. With the advent of 5G and now, this coronavirus outbreak, I suppose all this type of remote surgery will become increasingly popular. So as I conclude my first session, my summary is that robotic surgery is the latest form of minimally invasive surgery. The first form was laparoscopic surgery, and robotic is a new upgrade of that. It was early adoption of robotic prostatectomy in the field of urology, which was actually the catalyst for rapid expansion of robotic surgery in other fields of surgery worldwide. The robot is just a tool. It's just a tool for the performance of minimally invasive surgery. What is important is providing minimally invasive surgery for patients. The robot is a tool, and it allows for a shorter learning curve. A bigger problem is, sustainable and cost-effective medical innovation and technology. And this remains a worldwide challenge for all health systems. This robotic technology is expensive and it is not readily available in the poorer nations of the world. And what we should do is to try and make these expensive medical technologies cost-effective and available for everybody. I will leave you with this quote from Ralph Klayman. Ralph Klayman was a great innovator in the field of urology, and he was the man who actually performed the first keyhole surgery or first laparoscopic surgery to remove a kidney about 30 years ago. And at that time, it took 6 hours to perform that operation, which now easily done within 2 hours. So Ralph Klayman, made this observation. This is his personal observation. He says, there's no doubt in my mind that surgery, and almost all surgery within 5 to 15 years, will be done robotically for no other reason that the robot doesn't get tired. The robot has a stable platform. The robot has enhancements that are superhuman and allows you to do things with the precision that in essence is not humanly possible, case after case. And he says, man alone will never ever win over man plus machine. So I thank you for your attention, and I'll be glad to take any questions.
Okay, thank you, Doctor. That was really very enlightening, from outer space to the inner spaces of our body. I had a couple of questions, Doctor, in terms of, and then as our colleagues type, then we can just go through, we can go through some of their questions on the chat box as well. Doctor, so in Malaysia, how many robotic centers are there if we want to look at in terms of prostate surgery?
Sure. So Hospital Kuala Lumpur was the first public hospital to get this. Many years, we were the only institution. At the moment now, all the robotic systems are only concentrated in the Klang Valley, and there are about 5 hospitals, one public hospital, which is Hospital Kuala Lumpur, 2 university hospitals, UITM and UPM, and 2 public hospitals, which is Sunway and Gleneagles. Okay. So there are 5 robotic systems, and I think the number of robotic surgeons are about 10 robotic surgeons, who perform robotic surgery at the moment. Yeah.
Right, Doctor. There's a question from a colleague on the chat. She asks, what is the success rate of robotic surgery? I'm thinking the question is directed to like prostate surgery, Doctor.
Yeah. So of course, how you interpret success or how you define success, there are many definitions. One is, was it safe for the patient? Did the patient go in and come out of surgery safely? What is your blood transfusion rate? What is the complication rate? So that would be the early kind of parameters you look at. Then you look at late parameters. What is continence rate? Was the patient able to control his urine after the operation? Was he able to have erections? What was the cancer recurrence rate? So there are many kind of outcomes that you're talking about. But if you were to compare these outcomes with open or laparoscopic or robotic, all the minimally invasive surgeries have all these advantages of patients coming for the operation and leaving the hospital within 2-3 days and able to return to work very much quicker with very much less pain. And those aspects, of course, minimally invasive surgery wins hands down over open surgery. So to the patient, he doesn't really know what we do inside. You know what patients ask me? How many sutures? How many sutures are you going to use, doctor? How big is the wound going to be? you know, when can I go and start, you know, playing golf or something like that, you know. So for the patient, these are the outcomes which are important. And of course, he wants to know, you know, will you cure me of my cancer? You know, will my
Right.
cancer recur? You know, so to the patient, these are the outcomes that are important. And in that aspect, of course, robotic surgery is very much appreciated by them, that you can do a surgery with a minimum of discomfort. They're very, very happy.
Okay, doctor, there's another question on our another colleague asks, may I ask about the robotic prostatectomy's performance in terms of tumor clearance compared to open surgery?
They are equivalent. They are equivalent. Uh, as you get more, and don't forget, the robotic technology is actually brand new. 2000, it was only came out in 2000. Now it's only 20 years. If you want to compare this to open surgery has been there for more than 50, 60 years. So you're trying to compare something relatively new to something which has been there for a long time. But as with new technology, it progresses at a rapid pace. More surgeons will use it, the technology will improve, and the results will get better and better and better. So even in this early stage, it already is as good as open surgery, you know,
Right,
and it can only get better.
right, right. And doctor, another question on, is there a choice of surgery when we're looking at, is it the surgery of choice for large posterior diverticuli of the bladder?
Yeah. Large diverticular, the bladder, you know, a bladder diverticulum means there's an outpouching of the bladder, you know, and in a lot of patients, you may not need to do any surgery. But if you did need to do surgery, if you did need surgery, again, you can choose open, you can choose laparoscopic, and you can choose robotic. You know? So if you're in a place where nobody knows how to do minimally invasive surgery, of course, you get it done in an open fashion. If you have access to a surgeon who can perform it laparoscopically, of course, it's much cheaper than robotic. So I would always choose a minimally invasive surgery over an open surgery. I mean, it's intuitive, isn't it? Because you don't want to have a big scar. You want to be, you know, you want to get better faster. And if I choose a minimally invasive surgery, then I got a choice between robotic and laparoscopic. You know, and that just boils down to availability of technology and availability of expertise, and of course the financial bill. You know, so a patient will think of these three things and make his decision. Of course, if money is not an object, of course you would go for minimally surgery and every time. You know.
Mhm. Sorry, doctor, just to kind of continue on that line of questioning, just for, I think, quite a lot of people who are curious. In terms of cost, doctor, if you're talking about prostatectomy, just comparing apple to apple, if you're talking about laparoscopic surgery versus robotic surgery, I mean, a very rough estimate of the cost difference, like in terms of, yeah.
So robotic surgery in the private sector is about somewhere between 50 to 55,000.
Okay.
Laparoscopic surgery, I'm sure it will be much less than that, maybe 25, 30. Yeah.
Okay.
Yeah.
Okay, will do, doctor. And there's a question from another colleague on operation time. Is it longer than laparoscopic or open surgery for same kind of procedure when compared to robotic surgery?
Like I was telling you about, Ralph Clayman, when he performed the first laparoscopic nephrectomy, it took 6 hours. His boss walked into the theater, took out the clock and put up a calendar on the wall because it was taking that long. But of course, now we do a laparoscopic nephrectomy within 2 hours. Okay, so as quickly at the moment you pick up your experience, all three procedures usually can be performed within 3 hours, 3 to 4 hours, depending on the complexity of the procedure, of course. But it takes you time to reach that proficiency to be able to perform operation relatively proficiently during and about a say 3 hour period. 3 hours. It will take about 3 hours. Yeah.
Right. Right. Is there a role, doctor, for robotic surgery in other kind of cancers such as breast? Has it been used now in breast cancer, surgical procedures? Any thoughts on that, doctor?
The robot is an expensive piece of technology. So if you're going to use it, there should be an obvious advantage. If you use it when there's another similar kind of technology which is much less expensive and can give you the same results, you should use a less expensive technology. You cannot be using the same tool for every procedure under the sun. That's not really economical. So I would choose robotic surgery for those complicated procedures which require reconstructive work. Like for instance, taking out a kidney, for instance. You can take out a kidney for cancer of the kidney via an open, via laparoscopic, via robotic. At the current setting, almost nobody does it open anymore. Everybody gets it done laparoscopically. Of course, you can use a robot, but it will be an overkill. You don't need a robot to take out a kidney, which can easily be done by most surgeons who are skilled in laparoscopic surgery. But robotic prostatectomy, to do it laparoscopically is challenging. There are people who do it, yeah. Using the robot is much more accurate. I feel is much more accurate, and your results are slightly better. So I would choose robotic technology if I was going to do a prostate operation. But just taking out a kidney, for instance, I would say you can use it. You can do laparoscopically. You don't need to have a robot.
Right. Will do, doctor. So I think I don't see any more new questions at this point in time. I'm also conscious of the time and what is this? The fact that we will be keeping you for a lot of time. So I'm going to ask gently if any of our colleagues still have any more questions. Please feel free to continue typing onto the chat box, and then we'll get to it right at the end of the second segment. And so, as you all are aware, the CME attendance depends on, of course, the fact that you all are attending. And we put up 2 code words. So the first code word I'll be very happy to give you now. And I think it's something that Mr. Murli has been talking about over the course of this session, which is prostatectomy. So the first code word really is prostatectomy. Please feel free to kind of fill that in. And I'm going to turn that back to Mr. Murli so that he can go on to the second segment of today's session. Doctor, back to you.
Okay, thank you. Which one is coming up here? This one, This one, Okay, thank you, Murli. And I hope the first presentation was not too overwhelming.
Oh, no, it wasn't, doctor. It was so interesting.
Oh, thank you. Okay. So my second talk is, of course, more the bread and butter talk, and it's entitled PSA and prostate cancer. Okay. So let me see now. Okay. So this is where your prostate gland is. It lies at the base of your penis, just below your bladder. If you were to look at it from the side, that's the bladder here again. That's the prostate, and this is your urethra. So you pass urine from the bladder through the prostate to the tip of the penis, and the testicles are somewhere around here. So the bladder sits on top of the prostate, and this orange organ here is your prostate. At the back of the prostate is another organ called the seminal vesicles, and this is where your sperm is stored. So the prostate gland has got a common channel for urine to go through and for sperm to go through during ejaculation. And the size of this prostate in a young man is about the size of a walnut. And that's why the walnut is an international symbol for the prostate, because it's approximately the same size and the same weight, 20 grams, about 20 grams. Now, as a man gets older, once he reaches over the age of 50 years, this walnut will slowly get bigger. And in most patients, by the time you're 55, 60, your gland will become about the size of an orange or a golf ball, and that's about 40 grams. And that's what we refer to as BPH, or benign prostatic hypertrophy. Of course, in some men, this gland can even exceed, weights of 100 and 200 grams. 40 grams is about the average size of some of the prostate in most of the elderly men. But you must remember that BPH can also coexist with prostate cancer. It means as you get older, not only your gland gets bigger, but you also have an increased chance of getting cancer in the gland. And sometimes it's difficult when someone comes to you, with problems with passing urine, to decide, is it just a BPH, or does this man also have cancer in addition to BPH? That's the difficulty. So how common is prostate cancer? So prostate cancer is actually a disease of the Caucasian man and the black man. So you can see from this pictures here, all these men have prostate cancer. And some of them are actors, some of them are politicians. I'm sure I'm sure you'll be able to recognize some of the famous faces here. Sidney Poitier, To Serve With Love, Warren Beatty, one of the richest men in America, Harry Belafonte, the singer, Nelson Mandela of South Africa, John Kerry, the previous Secretary of State, Colin Powell during the Gulf War, Robert De Niro, Ben Stiller, the Shah of Iran, Arnold Palmer, the ex-golfer, the legendary golfer, Roger Moore, the saint, Ian McNeil, I think, I've forgotten this guy's name, but he acted as Gandalf in the, one of the, I don't remember, Star Wars, is it? Yeah, so there are many famous men in the Western population who have got prostate cancer. And in the West, these men are not afraid to come out publicly and say, I have got prostate cancer, and I urge all American men to go and get your PSA done. So in the West, because they have many icons who've got prostate cancer who come out publicly to increase the awareness of prostate cancer in the West. So in the West, when you pick up prostate cancer, it's usually at an earlier stage. So as we were saying, the worldwide incidence of prostate cancer. So the incidence this is the incidence in green, okay? So you can see in the Caucasian countries, US, Sweden, Canada, Switzerland, France, Australia, the incidence of prostate cancer is very high. They have got a genetic predisposition to prostate cancer. Whereas the incidence in our part of the world down here is very low. So genetically speaking, the white man and the black man has got a higher risk of prostate cancer as compared to us in Southeast Asia. But as I told you before in a previous slide, this situation is changing. And if you were to compare the incidence of prostate cancer in the 70s to the 90s in Southeast Asia, among the 6 countries in Southeast Asia, you can see that in all of them, the percentage, the incidence of prostate cancer is on the rise. And in the more developed nations of Southeast Asia, which have PSA testing, the rise in prostate cancer is more than 100%. So in our part of the world, these are some of the people whom you might know who have got prostate cancer. The present Singapore Prime Minister and the previous Singapore Prime Ministers, both of them, had prostate cancer and both had them at surgery. This is the religious leader from past. He died not because of prostate cancer, but he had very aggressive prostate cancer, which is called metastasized. the ex-emperor of Japan had prostate cancer. So if you look at the top 10 cancers in Malaysian men, prostate cancer is number 4. Large bowel is number 1, lung is number 2, nasopharynx is number 3, and prostate cancer is number 4. And this was somewhere in 2005. In 2020, prostate cancer now has risen to number 3 place. It's now the 3rd most common cancer in Malaysian men. Recently, you may have heard this man. His name is Nazir Razak. He's the brother of our previous Prime Minister. He had prostate cancer and he had surgery done. And he took it upon himself to become an icon for prostate cancer. That means he goes on TV, he goes on radio, he says, I'm a prostate cancer survivor. Please go and get your PSA done. So he is doing all this to raise the awareness of prostate cancer and to promote prostate cancer screening. And one of the key messages that he says time and time throughout his interviews is that in Malaysia, 60% of Malaysian prostate cancer patients, when they are detected, they are already at stage 4. Stage 4 means metastatic disease. The cancer has already spread out of the prostate into all the other organs. And this is in direct comparison to the Western countries where only 10% of men, when they are discovered, have metastatic disease. And this points to the fact that Malaysian men are not aware of prostate cancer, and many of them are not aware of what a PSA test is. And so Nazir Razak is doing his best to increase awareness of prostate cancer. So at least in Malaysia, we have one icon who at least, he's doing his bit to increase the awareness. One celebrity, you can call it that. So from the primary healthcare point of view, now that you know that prostate cancer is on the rise in Southeast Asia, the question is, who should you be investigating for prostate cancer? So you can divide this into 2 types of indications for performing PSA testing in your patients. The first is easy. It is called case finding. That means to say any symptomatic man that comes to you with voiding problems, you should automatically do a PSA. This is not screening. This is because the man is coming to you already. He has got voiding problems, and that means he could have BPH or he could have prostate cancer. So you are obliged to do a PSA. Something which is more controversial is screening. Are you going to do PSA for somebody who walks into your clinic completely asymptomatic, no voiding symptoms? Would you do a PSA? So the answer is, in asymptomatic, healthy men who are well informed, over the age of 50, who wish to be screened, yes, you should do a PSA. Because these men, well-informed men, means they understand what is prostate cancer. They know that early prostate cancer has got no symptoms, and the only way to kind of detect prostate cancer at that stage is to do a PSA. So asymptomatic, healthy, well-informed men over the age of 50 years is somebody who you might want to do PSA screening. And if they have a family history of prostate cancer, then it becomes even more important to do PSA screening, because it's well-known fact that if you have somebody in your family, either your brother or a father who's got prostate cancer at an early age, you are 4 times more likely to have prostate cancer. So family history of prostate cancer is a very important piece of history that you must always ask. In the West, now more and more men go for genetic screening. And if they pick up the fact that you have a BRCA2 gene mutation, then these men are more prone to have prostate cancer. They're also more prone to have more aggressive prostate cancer. They are more prone to have prostate cancer at an earlier stage. So men who are known to have a BRCA2 gene mutation, they're usually advised to do they're usually advised to start prostate cancer screening at an earlier age, somewhere around 40s, you know. And even if you are someone who has got family history of prostate cancer, it is advised you start screening early at the age of 40. So there are some guidelines which suggest doing a PSA, just a single PSA at the age of 40 is quite useful. So I hope I've answered this question of whom should you do a PSA for? The easy scenario would be someone who comes with some voiding problems. And therefore, you're not sure, is it BPH, is it prostate cancer? You should do a PSA. Screening for PSA in asymptomatic men, yeah, you can do it for men who are over the age of 50, healthy men who you know are going to live for another 20 years. And they should be well-informed men. They should understand why you are doing this PSA screening for. And it becomes more compelling to do screening in people who have got family history of prostate cancer and men who have got this BRCA2 gene mutation. Now, for patients who are not decided, who can't decide, should I do a PSA or not? There are many sites, you know, where they can go and read about prostate cancer and make their own choice, whether they should go for PSA screening or not. So although, you know, you may introduce this topic, but the patient doesn't have to decide straight away in the clinic whether he wants to have a PSA done. You should give him these websites where he can go and read about a little bit before deciding, you know, should I go for PSA screening? The other way in which he could help himself is to go online to one of these free prostate cancer risk calculators, you know. And one such calculator is a swab calculator, where you put in certain parameters, you put in certain information, and it will give you what is your own individual risk of having prostate cancer. So this helps the patient decide whether he would like to get a PSA test done or not. The other question that I get asked frequently is that if you were to do PSA screening, how often should you do it, and how long should you do it? So first, we'll take the frequency. We'll take the frequency of screening. How often to do it? So according to the guidelines, if you have a PSA of more than 2 at 60 years of age, you are someone who is at risk of developing cancer in the future. If you happen to have done a PSA at the age of 40 and it was already more than 1, you again are at a higher risk of developing prostate cancer in the future. So for these kind of values of PSA, it is recommended that you do screening every 2 years. Okay, if you're not in this group, then you can kind of move the interval, the PSA interval, PSA testing interval, to every 8 years. Okay, and it's also recommended that you stop the screening in asymptomatic individuals when the life expectancy of that individual is likely to be less than 15 years. That means when the patients get very old, 80 years old, for instance, I don't think, you know, you're going to benefit them by picking up prostate cancer at that age. So this is the duration and the frequency of screening. If you happen to be in this particular risk group, then you should have PSA done every 2 years. If you're not in this risk group, you can postpone the PSA testing to every 8 years and stop screening once the man is very old, or he's got too many comorbidities that would lead you to believe that he's not going to be alive, in 15 years' time. So prostate cancer detection, of course, starts with a rectal examination. And you can see from this diagram here, the prostate gland is just above the anal canal. So when you put your finger in the rectum, you can feel the prostate. But of course, you can only feel one edge of the prostate, the back of the prostate. You can't feel the front of the prostate. You can't feel the top of the prostate. You can only feel the back of the prostate. And the feeling of the prostate will be like the feeling, will feel rubbery, just like the tip of your nose. If you touch your nose, that will be how the prostate will feel. So if the prostate feels a bit nodular or a bit hard, then you have an increased suspicion of prostate cancer. But of course, we all know a digital rectal examination is very non-sensitive. It depends on how sensitive your finger is. So a much better test is, of course, a PSA test. Of course, you can see the reference range for PSA internationally is 0 to 4. Anything higher than 4 is high. Okay? PSA testing, PSA stands for prostate-specific antigen. It is a substance only produced by the prostate gland and no other gland. So the PSA is produced by the prostate and it sits inside the prostate gland. Of course, some of it escapes from the blood into the blood, from the prostate into the blood, and we can detect this as a PSA test when we take peripheral blood. And the normal level is 0 to 4 nanograms. Nanograms is a very small amount. So the amount of PSA in your bloodstream is actually very, very small. There's only a small amount of it which escapes from the prostate. When you have cancer in the prostate, a lot more of this PSA escapes into the blood. You get a higher level. If you get infection in the prostate, again, a lot of PSA is released into the circulation and your level goes up. So serum PSA, the PSA is organ specific. That means it only comes from the prostate, but it is not disease specific. That means to say if your PSA goes up, there is a variety of causes. BPH is a common cause. A bladder stone. If you have a stones in the bladder, these stones sit on the prostate, irritate the prostate and cause the PSA to go up. Acute retention of urine will cause the PSA to go up, as does urethral instrumentation. If you were to put a CBD into somebody, this can cause the PSA to go up. And of course, infection, prostatitis and urinary tract infection. In fact, one of the ways of diagnosing acute prostatitis is if you do a PSA and the PSA is high and the patient is very symptomatic, you would diagnose prostatitis. Some people say even ejaculation in the previous 48 hours can cause the PSA to go up. And certain kinds of sports activities, for example, mountain riding, horse riding, cycling, where the perineum gets hit repeatedly, on a hard seat, it can cause can cause the PSA to go up. And of course, what we are interested in urologists is prostate cancer. So if someone comes to you and you do a PSA and the PSA is raised, what would you do? First of all, you'd have to rule out all the other causes before you think of prostate cancer. That means you've got to think of BPH, you've got to look for infection, you've got to do ultrasound of the bladder, you have to do urine FEME, urine CNS, ask the patient about his activities, and maybe even repeat the PSA at 6 weeks later and see whether the PSA is still raised. So if you have ruled all this out and the repeat PSA is still high, then you should start thinking of prostate cancer. So that's the way to go about it. So once you've done a PSA and the PSA is high, you have ruled everything else out. So now it only leaves the risk of prostate cancer. So the patient might ask you, doctor, what's my risk of prostate cancer? Okay. So even for that, there are online risk calculators. For example, take this man here. He has done a PSA. His PSA is 7. Okay. So he's had to answer this question. Have you ever had a biopsy of the prostate? No. How old are you? 60 years old. What's your ethnicity? You're not black, you're not white, so you have to put others. Do you have a family history of prostate cancer? No. When the doctor did your rectal examination, did he say your prostate looked funny? He said, no. You know, what is your PSA level? 7. Then you hit the calculate button and you calculate down here. The probability of having any kind of prostate cancer in this man is about 20%. The probability of having high-grade prostate cancer, that means the dangerous type of cancer, is 6%, maybe 7%. So now the patient has to look at this and decide for himself, I've got a 7% chance of having aggressive prostate cancer and about a 20% chance of having any other kind of prostate cancer. Should I go for a biopsy? See? So this kind of online risk calculators helps the patient decide after he has done a PSA, should he go for a biopsy? So when should the general practitioner refer the patient to the urologist? So if the initial PSA is straight away more than 4, the GP has ruled out all the other causes, infection, prostatitis, BPH, stone, you know, and he has repeated the PSA and still more than 4, then that patient will need to see a urologist. The second group of patients is patients who are on a screening program. That means they do the PSA every 2 years or every 8 years or whatever it is. And the PSA keeps rising. There's a rising trend with repeated screening over the years. This guy should also see the urologist. Now, a word of caution. Many elderly people are also taking 5-alpha reductase therapy for BPH. 5-alpha reductase therapy are drugs like Proscar and Avodart. And these drugs artificially drop the PSA by half after about 6 months. So in those patients who are taking these types of drugs, whatever PSA value you have must be multiplied by 2 to get the actual PSA. Yeah. So if a patient has a PSA of 4 while he's taking Proscar, his real PSA is not 4, it's 4 times 2, which is 8. And that's already more than the upper value of 4. So he should be referred to the urologist. So in addition to all these PSA factors which should direct a urology referral, there are also clinical factors. That means patients who've got normal PSA, but they've got clinical risk factors. For example, you do a rectal examination and there's a nodule on the prostate. Even though his PSA is normal, he should be referred. Patients who've got hemospermia are also at slightly higher risk of prostate cancer. So this would be the type of patients who you would be worried about and probably ask for an early urology referral. Now, when you refer the patients to a urologist, those days, when the PSA was high, we would straight away do a biopsy. But currently, more and more of us are asking for an MRI scan of the prostate before the biopsy. Yeah. So there's a twofold reason for this. The first is after you stick a lot of needles into the prostate, and then you find you have cancer, and then you want to do an MRI to stage the cancer, there are a lot of artifacts, in the imaging because of all these hematomas you have created with the needle. And the second reason for doing the MRI of the prostate is, if the prostate on the MRI is completely normal, you may save the patient the biopsy. You may say, well, your MRI is completely normal, although your PSA is high. We can maybe delay the biopsy and follow you up with a few more PSA results. So this MRI scan of the prostate is a special MRI scan. It's known as the multi-parametric MRI scan. It is a niche investigation. That means to say not many radiologists are trained to properly do a multi-parametric MRI scan. When we first had the robot in the HKL, nobody in Malaysia knew, none of the radiologists in Malaysia even knew how to read a multi-parametric MRI scan. Now, of course, more and more radiologists are being trained in the use of a multi-parametric MRI scan. So here you can see the patient is about to go through the scanner. That's the prostate here. And you can see there's an obvious, lesion somewhere around here. So when the doctor is doing the biopsy, we know where to target, where to stick our needle in. Before this, we were just doing in a random fashion. Before we had the MRI, we just used to stick the needle in a random fashion all over the prostate and hope we would pick up any prostate cancer. Now with the MRI, our biopsy is a bit more accurate. We know where to concentrate our biopsies. So it makes the whole process more accurate and more efficient. Regarding prostate biopsies, there's two ways of doing it. The standard gold method way, which is done worldwide, is transrectal. It means we put a ultrasound into the rectum, so we can visualize the prostate on an ultrasound screen. And through the same probe, there's a needle which passes through the ultrasound probe, through the rectum, into the prostate, and takes a biopsy of the prostate. So this is the time-honored way of doing it. It is done as an outpatient under some sedation, and it's daycare procedure. The patient can go home. All biopsy procedures have got, some complication rate like, hematuria, blood in the stool, and urinary tract infection. The transrectal prostate biopsy has about a 1% chance of severe sepsis. And this is because you are going through the rectum, which is not a clean area. So this severe sepsis can, can result in death, or can result in you having to be admitted for hospital, having weeks of antibiotics, So although it's a very, 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 very small risk of sepsis, it's quite an important risk. Now, if you're doing, tens of thousands of transrectal biopsies, and if you get a 1% rate of sepsis, that's still quite a lot. So because of this danger of sepsis, a lot of urologists have now moved towards a transperineal prostate biopsy. Meaning to say, although we put the ultrasound into the rectum to be able to visualize the prostate on a computer screen, the needle that is used to take the biopsy doesn't go through the rectum, but goes through the skin just below the scrotum. That's called the perineum. So the needle goes through, transverses the skin just below the scrotum. So that's called a transperineal biopsy. Because this needle doesn't go to the rectum, the rate of sepsis, severe sepsis, is almost 0%. And the other advantage of doing a transperineal biopsy is you can take a lot more biopsy cores. It is slightly more accurate because you can reach the anterior bit of the prostate. If you're doing it from transrectally, sometimes it's a bit of a chore to pass the needle through the rectum, right through the prostate, to kind of get to biopsy this bit of the prostate. Whereas you go for the transperineal route, it's a straight shot. And the other advantage of transperineal biopsy is there are some machines which can do a fusion biopsy. A fusion biopsy means they take the MRI that you have done previously and fuse it to the ultrasound pictures so that it becomes very accurate. You can place your needle exactly where you think the lesion is. So this transperineal fusion biopsy is the next generation in prostate biopsies. And therefore, we are slowly moving away from transrectal to transperineal and then transperineal fusion biopsies. Now, despite all these advances in MRI and biopsy techniques, ultimately, it is the pathologist who will decide whether you have prostate cancer or not. Okay? So we send these tissues to the biopsy, and she will confirm, number one, do you have prostate cancer? And number two, what is the grade of the cancer? So prostate cancer, you can grade them, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, somewhere in that region. And low-grade cancers are 6 and below. Okay, those are the low-grade cancers. They are called the pussycat tumors. These tumors, 6 and below, generally speaking, do not harm the patient. They do not affect overall survival of the patient. And therefore, in the majority of low-grade cancers, no active treatment is required. Just active surveillance. That means you tell these patients this cancer is unlikely to cause you problems in your lifetime. And therefore, but they need to be followed up, of course. So you follow up with a urologist with regular PSA, regular, rectal examinations, maybe a repeat MRI, or maybe even a repeat biopsy in 1 or 2 years' time. And the majority of patients in this group will not progress to this group. So low-grade cancers are managed expectantly. No need for immediate curative treatment. Whereas cancers which are high grade, that means the pathologist has given you a grade of 7, 8, 9, or 10, those are considered the high grade cancers. And these are the cancers that will probably harm you in your lifetime. And therefore, it is advisable that these type of cancers, you seek curative treatment. That means the treatment that you receive should try and cure you once and for all. So if you have a high-grade cancer, the curative treatment for high-grade cancer just falls into 2 categories. You either choose surgery or you choose radiotherapy. And you should have a discussion, between yourself and the surgeon and yourself and the oncologist, which is the best treatment for you. For radiotherapy, there are a number of types of radiotherapy that you would have heard of, 3D conformal, IMLT, tomotherapy, gamma knife, brachytherapy. Each type of radiotherapy would say they are better than the others. So there's a whole plethora of types of radiotherapy that you can choose. But basically speaking, in principle, the radiation is given to the prostate to destroy the cancer cells, but the prostate gland is not removed. That means the cancerous organ is still kept in the patient. The duration of treatment for most of these types of radiotherapy is 6 weeks, although SBRT or gamma knife, they can shorten the duration of the treatment. And during the process of treatment, the patient will experience some bladder and bowel irritation. That means you'd always feel like you want to empty your bladder. You'd always want to empty your rectum. Most of this bladder and bowel irritation goes off, but there are a few unfortunate individuals in which it may remain. Okay. And radiation therapy may be given by itself, or it may be combined with hormonal injections for 6 to 12 months. Hormonal injections means you give some injections which takes away the male testosterone. That means you will be artificially inducing menopause in a man for at least a duration of 6 to 12 months. So it's a combined treatment. For surgery, on the other hand, the cancerous gland and the surrounding lymph nodes are completely removed. The lymph nodes are removed in some of the patients because when the cancer spreads, the first site it normally spreads to is the lymph node. And that's why in patients with high-risk prostate cancer, We remove the lymph node to see, has the cancer spread to the lymph nodes? Surgery is usually the treatment of choice for the younger and the fit men. Of course, surgery, there are risks, and these risks are incontinence and erectile dysfunction. These are the two risks for surgery. And now, of course, as I mentioned in my earlier lecture, we have got minimally invasive surgery. Instead of making a big incision, you make small little holes. This is
and delicate nerves that affect both urination.
So this is the bladder up here. This is the prostate gland, and this is the penis. And surrounding the prostate gland are all these nerves which travel to the penis and give the man an erection, responsible for erectile function in the man. So in prostate cancer surgery, we try to remove the prostate gland and preserve all these nerves in order to let the man still have sexual function post-operatively. Of course, there's a big hole now. You've taken the prostate out, and therefore you have to join the bladder back to the penis. You know? And also, around here are also all the muscles that give you continence, that allow you to, you know, hold your urine. And all these muscles also will be damaged during the surgery. So that's why after surgery, there will be a period of time where you will have to wear Pampers because you cannot control your urination. And if we are not able to preserve the nerves, you will not have erections post-op. So these are the complications after surgery. So of course, the million-dollar question that patients always ask me, Doc, which is better, surgery or radiotherapy? You know, and there's so much in the internet, there's so much in the medical literature. You will find 10 studies which say surgery is better. You'll find another 10 articles which say radiotherapy is better. So how do you choose? So luckily for us, all this medical literature are shifted through are looked at by experts, you know, experts in the field of prostate cancer, both radiologists, both surgeons. They go through an evidence-based kind of algorithm, looking at all this literature, and they will come out with guidelines, international guidelines, which all of us follow, whether we are radiotherapists or whether we're surgeons or whether we're radiation oncologists. We all follow the evidence-based medicine, which is produced in the form of guidelines. For example, these guidelines are updated almost every 1 or 2 years. And so here I'm looking at the 2020 European guidelines for prostate cancer. Most of us look to the UK for our guidelines, and the UK follows the European guidelines. So this is the latest guidelines on prostate cancer. So it says guidelines for the radical treatment of high-risk localized disease, means a high-grade disease. So here's the recommendation, and here is the strength rating. So recommendation, radical prostatectomy. Radical prostatectomy means surgery, and the strength rating is strong. Then you go down and look for radiotherapy. Radiotherapy, external beam radiotherapy for prostate cancer. Again, the strength rating is strong. So both surgery and radiotherapy have the same strength rating by the European guidelines. So both of them have similar outcomes. Similar outcomes means survival rates. You know, the patients survive almost equally, whether you take surgery, whether you take radiotherapy. Recurrence rates after prostate cancer treatment, 30 to 50% will have a recurrence. So the recurrence rates are also the similar. So there's still a debate among urologists versus radiotherapists. And here you can see this cartoon. You know? It's like a married couple after an argument, each sitting in his own chair, each thinking he is right and the other is wrong. But in truth, both treatments have equal cancer survival, but they have different side effects. Surgery has different side effects. Radiation has different side effects. So the patient has to decide. And therefore, it's very important that men receive balanced information about the two types of treatment. And when we inform patients, we ourselves must know what are the potential benefits, what are the potential harms, what are the potential outcomes. So counseling is ubiquitous, it doesn't matter whether you're talking with patient with diabetes or prostate cancer or whatever. We have to know the potential benefits, potential harms of all the treatments that we are offering the patient, and we should be able to present it in a language that the patient understands. This, of course, is the wrong way to counsel patients, in a kind of a paternalistic kind of, I'm telling you, you should do this. This is a very ancient and very archaic way of counseling patients. We encourage patients, I encourage patients, ask the right questions before you go for any kind of treatment, What are my chances of cure? What are the side effects? What are the cancer recurrence rates? What are treatments needed if and when the cancer recurs? Because I tell them, 30 to 50% of your cancer is going to recur, whether you choose, where to get the answers. Consult the urologist, consult the oncologist, get both opinions. You can get a second or even a third opinion. There's a lot of information you can get from cancer survivor groups in Malaysia. There's a huge amount of patient information from major cancer institution websites. So I always advise patients, do your homework, don't rush into any treatment. Come back, ask me all the questions you need to, and then decide. There was this recent article on why men choose radiation, why they chose radiation, why they did not choose radiation. So when you look at these answers, you can get some idea into the perception by patients, you see, why the patient did not choose radiation, because he thought it was not as good as surgery. He was unsure if the cancer would be completely gone by radiotherapy. He was worried that he may not be able to have surgery if the cancer recurs. Why did they choose radiotherapy? Because they thought it's as good as surgery, less invasive, fewer side effects, more technology, more precise. And similarly, regarding surgery, why some men choose surgery and some men choose not to have surgery. So you look at the reasons why you chose, offers the best chance of cure. Cancer is gone, don't have to worry. Get it over with and move on with life. I still can do radiation if the cancer recurs. Doctors recommend it. Friends who went through had good results. The best way to know if cancer is spread. Fear of radiation. Want to live at any cost. Cancers to robotic surgery, more precise, less invasive with future effects. Celebrities, well-known people who've had surgery were cured. Why I did not choose surgery is more invasive, more side effects. I can't ensure the nerves would be spared. That means, he was scared of erectile dysfunction, had to stay in hospital. I may die from anesthesia or surgical complications. Disrupt my work at daily routines, painful, So why a patient would choose surgery over radiation? There are many, many reasons. It is the role of the doctor just to counsel them on the pros and cons, and they will choose themselves. For example, these men chose surgery. Nasir Razak, Roger Moore, both our prime ministers, Andrew Lloyd Webber, Stephen Fry, who was a very famous British comedian, Colin Powell, Ben Stiller. These are the patients, Arnold Palmer, these are the patients who chose surgery over radiotherapy. And then if you look at the patients who chose radiotherapy over surgery, Rod Stewart, Rudy Giuliani, he was the mayor of New York during 9/11, Charlton Heston, Nelson Mandela, Warren Buffett. So men choose one form of treatment, after based on many, it's multifactorial, why they choose one over another. So just remember, whether we're talking about a $12 million robot or a $60 million radiotherapy machine, they are just machines. It is important to choose your treatment, to choose the type of treatment that you are comfortable with. And it's important to choose a doctor that you're comfortable with. And in generally speaking, high volume experienced consultants generally have better outcomes. Prostate cancer is a slower growing disease. From the time you have localized cancer to locally invasive, metastatic, and finally death, it takes about 10 to 15 years. Okay? So the type of treatment that you're going to get depends on the stage of the disease. We are trying to pick up people here with early PSA testing. Localized prostate cancer, where you take either surgery, radiotherapy, you can get a cure. Up to about 50 to 80% of people can get cured. Because if you catch the cancer later, of course, there's still treatments. There's no such thing as no treatment. You get treatment, but the burden of treatment gets bigger and bigger and bigger, and the quality of life issues get more and more. So although prostate cancer is a slow-growing disease, it is better always to pick it up earlier, where the chance of cure is much higher. So with that, I will end my talk, and I'm happy to take any questions.
Thank you so much, Doctor. I think there's quite a few questions. On my part, I think really it was quite a comprehensive kind of overlook and a lot of good insights. Actually, I think for our colleagues who manage patients, at the primary care level, Doctor. First question, Doctor. There is a question on whether will prostate cancer always show up as elevated PSA levels.
The majority of prostate cancer will have elevated PSA levels. There are a few cases I've seen where the prostate level is normal, but the rectal examination picked up a nodule. So it's important that you do both together. And the other point I want to pick up is sometimes it is a trend in PSA which catches your eye. Sometimes one PSA doesn't really need much, but if you ask the guy, show me your previous results, even he was PSA, say 3.5. But if you look at his previous result, he started from a 1 to 2, and 2 went to 2.5, and that trend already is alarming. Even though his PSA is less than 4, the trend is alarming.
Right. Will do, Doctor. Another question from another colleague. Does the family history of bladder cancer increase the risk of prostate cancer?
Not really, no.
Okay. Is another question on, is the risk of getting prostate cancer higher for people with BPH than those without?
Not to my knowledge, no. They're just two conditions which coexist, but not that BPH increases the risk of prostate cancer, no.
Right. Got it, Doctor. Prostate cancer due to prosca or avoduct. Any thoughts on that?
Yeah. This is controversial. Initially, they thought by using these drugs, you could actually decrease the incidence of high-grade prostate cancer. But to their surprise, the results were not what they thought. And therefore, these drugs are not used to prevent cancer. Whether they actually cause cancer, I seriously think they don't. I don't think they cause cancer. My only caution to the GPs is, if you're giving these people these drugs, just make sure the PSA you must times 2. If you don't times the PSA by 2, you will get into a false sense of confidence that the PSA is low. That's my only reminder to the general practitioners.
Right. There's another, I think this is a comment more so than anything, but I'll just share it with you, Doctor, to see whether you want to give some comments on it. If all men live up to the age of 100, the chances of getting prostate cancer is 100%. Unfortunately, prostate cancer is, it should be screened in as men advance with age.
Yeah, I totally agree with that. As you get older and older, your chance of getting prostate cancer is higher and higher. We as urologists, we are only interested in picking up the high-grade cancers. We are not interested in picking up the low-grade cancers. That's why our style of doing things has changed. We do the MRI first. We ask for history of family cancer. We examine you. If we think you're low risk prostate cancer, which is not going to harm you, I don't think you should be. You should even have the biopsy done in the first place. Our job is to pick up the high risk cancers that will cut into your life expectancy.
Right.
That's the whole idea.
Right. Another question, Doctor. What is the sensitivity of PSA?
The sensitivity of PSA, very sensitive test. That means to say, if you have prostate cancer, it'll pick it up. But it's very specific in the sense that if your PSA is high, it doesn't mean you have prostate cancer. It could be a variety of other causes, which I mentioned, BPH and all these kind of things. So prostate cancer, PSA, as I tell my patients, it's an alarm bell. If you hear an alarm bell going off, it just the possibility that something is there, so you can go and get something done. That's all, alarm bell. And then after you go and look around and you find there's nothing wrong, fine. You're much more relieved, really.
Okay, Doctor, two more questions at present, and then let's. I'm just going to reevaluate how long we want to go on this. An interesting question of how common does prostate cancer present as hematospermia?
Unlikely, Hemospermia, if you read the textbooks, they say it is a benign condition. But I have seen at least maybe about 3 or 4 patients who have been referred to me with hemospermia, which turned out to be prostate cancer. So my take on this is, if you have hemospermia, you should do your PSA and do your rectal examination. Hemospermia itself probably is not an indication of prostate cancer, but if you do these two and those two are abnormal, then you start really thinking of prostate cancer.
Right. Will do, Doctor. And let's take one more. So this one may be quite kind of significant for all of us to take note, because our colleague asks Dr. Murali on whether should I speak to the patient when they screen for PSA, because it leads to unnecessary worries or interventions which may cause more problems. I suppose the question is, what is the narrative that I shape around sharing with my patients during consultation for doing the screening or with the results?
Well, I think this is a bit of a difficult question. I think you should know your patients, because I suppose general practice, people whom you're going to do PSA are your regulars, not the guy who just walks in, for URPI or something, in clinic. I suppose the people whom you're going to discuss PSA screening are your regular oldies who come all the time. People, you kind of know those health-seeking people who come in for little things. They want to make sure, doctor, I want to do this, my tumor markers. Those are the kind of people, health seekers, who would be more receptive to, doing this test. You have to, I think, play it by ear, I think, This is where the art of medicine comes in, not the science of medicine, Right. You've got to have that kairos in your hand to know which patient is going to be, amenable, which patient must say, nah, I'm not bothered, you see. Yeah. So it's a bit of a...
Right. There's another question, Doctor, on this colleague of ours asks, in public hospitals...
I read that thing, yeah. In public hospitals, they do the biopsy before the MRI. Now, MRI is something, MRI is a new kid on the block. It has just come about, So in certain countries, like in UK, for instance, you will never get a biopsy without MRI first. They always do an MRI first, and then they do a biopsy. In places like Australia, MRI first. But this policy of doing MRI before a biopsy has not come into the international guidelines as yet. So it is not the current standard of care. Maybe in a few years' time, when it's in the guidelines, you must do an MRI before biopsy, then it will be very difficult to deny a patient, But at the moment now, it is not under the current standard of care. we can say, look, we don't have enough MRI machines, we don't have enough radiologists, we are not able to offer the service. This is an optional thing. If you really want to do an MRI, you can go and do it privately and then come to us for a biopsy. You know, it is not a standard of care, it's an option at the moment anyway, you know. So optional, I mean, the public hospital will offer you the minimum standard of care. It cannot offer you, you know, beyond that. Beyond that, you will have to, you know, pay some money and go somewhere else.
Yeah. And I think increasingly we can see what Dr. People need to move around to kind of beat the kind of queuing for diagnostics, and then you can come back in to get the procedures done. I think that's
exactly.
Yeah.
Especially now in the COVID era, where every public hospital is under a lot of stress, we have to postpone a lot of procedures. You know, the queue gets longer.
Yep, unfortunately. I'm going to take one more question, ladies and gentlemen, which I think is already down from, I think, Dr. Hari. He asked, besides aging and hereditary causes, any other risk factors we should be concerned about?
Well, as I said, it was aging, family history of prostate cancer, and the BRCA gene. You know, these are the three well-known factors. Then a lot of other factors which are, you know, kind of, people say if you've got metabolic syndrome, if you're overweight, you know, if you're diabetic, but these are very, very not really proven as, you know? Yeah. But these are the three well-known risk factors. You know?
Right. Will do. Will do. As we unfortunately have to wrap up, as it's really we've had quite a good long session with Dr. And I think really please allow me to represent everybody in thanking you so much today for spending quite a bit of your time and a lot of time preparing this wonderful set of presentations for us as well. Thank you so much, Doctor. Thank you so much for the sharing, and as well as your invaluable time on this weekend. So the second code word, ladies and gentlemen, is multi-parametric MRI. So feel free to, you know, spell it however you want, even if it's in short form. So again, the first code word, sometimes I've just been helpful. I'm just being helpful, sorry. So the first code word was prostatectomy, and now the second code word is multi-parametric MRI. And yeah, so put in that to get to submit your CME points. The link was already in the email that we sent you earlier to access the session. And also right after this, the session will be on YouTube. You still have about a week. We'll leave the attendance slots open for more than a week until everyone has the time to watch the YouTube video if you've missed it today, and kind of put up your attendance. So again, thank you very much, Dr. Mr. Murali Sundram, for spending his time with us. And also we'd like to thank Roche, our partners who have been instrumental kind of putting this whole session together since the beginning of the COVID pandemic, when we started this until now. So wishing everyone a very Merry Christmas and a Happy New Year, and hopefully we all pray for a better year ahead of us with some good vaccine protections coming in, hopefully. So take care, stay safe, and thank you very much again, Doctor.
Thank you very much. Thank you.